Well, good afternoon, everyone. A very warm welcome to everyone here who has come in and joined this program, which is related to the Dheera initiative, which is a flagship program of our beloved President, Dr. S. Shantakumari. Uh, this entire, we have about 75 registrations today, and I can see about 12 have joined in. So I'm not too sure what possibly is happening, but we would not like to delay any further and impinge upon the time for all those who have made it and joined the program today on time. Yeah, so as I was mentioning, this entire program is an initiative of Dr. Shantakumari, and we have partnered with UNICEF in order to support us both from a funding point of view as well as from a technical point of view to build the entire program as you see it today. The entire Dheera program has got three components. The first component is related to the Dheera school program, which is for 9th to 12th standard students across the country. And we have trained so far about 20,000 plus students, both girls and boys. Almost 15% of them are from the public school, and the rest are from the private school. We are hopeful that as we go along, we'll get more number of schools to be able to participate in this entire program. The second component related to the program is related to Dheera teachers program, which is nothing but the same program, but the teachers are also oriented on it so that in case the school decides to carry on with the program going forward for the upcoming 8th, 7th, 6th standard students, when they come to respective 9th, 10th, 11th, and 12th standards, they can continue with the program. And the last program for which each one of you are here today is related to the obstetricians and gynecological members of Foxy and their program, which essentially is going to talk about 8 topics, each anywhere between 12 to 15 minutes. And we already have the faculty here. Welcome, Monica, Prema, Gauri, Yasmin, Meeta, and that's about it. So we have about 5 speakers here who would be walking us through 8 important topics. Firstly is giving you the overview. Second is talking about how to approach a woman facing violence. What are the various effects of violence against women in pregnancy and childbirth? Mental health issues and how to tackle them. What are the various challenging situations in especially from a medical and a service provider point of view? This is a very interesting set of pointers through the slides. Then comes the support and systems, support systems that are available, the rehabilitation, the sexual violence, and how to approach a woman facing such a violence, and examination of the survivor, which is a very, very critical thing, and how to keep the records and how to approach and submit these records further so that a suitable action can be taken. And more importantly, how is that you can protect yourself from such a case, and so that you don't land up into any kind of a situation which may not be as healthy for you. Despite giving the best, we do not want you to get into that kind of a situation. So with that, I would warmly welcome Monica to please start the proceedings and walk us through the first module, followed by Prema, and then followed by Gauri. Please take over. I may have to join another meeting immediately, which is going to start at 4 o'clock. So I'll be jumping in and out and coming back to this meeting subsequently. Yeah. So Monica, over to you. So one of you can just take over while I'm not there and lead the entire. Okay. Thank you.
Sure. Thank you. Thank you, Mr. Ajay. So as a very beautiful overview has been given about this Dheera program, I will take you through the overview of violence against women, and let me just share the screen. Host, please enable me sharing the screen. Okay, thank you. Yeah, okay. Mm. Can you see the slides now?
Yes, ma'am.
Yes.
Okay. Okay. So I'll just briefly introduce myself. I am Professor Monica Gupta from VMMC and Safdarjung Hospital, New Delhi. And I'm also the nodal officer for the One Stop Center, which is like very much involved in the topic of discussion today in Safdarjung Hospital. And I acknowledge the slight credit for Dr. Kiranmai and Dr. Vindhya, and of course curated by Mr. Ajay, whom you just heard before me. So this is all this program is under the Dheera initiative by our dynamic president, Dr. Shanta Kumari, president of FOXY. And so I'll now take you through the violence against women overview. Again, I would like to sincerely thank those who were involved in shaping of this project, the team Dheera Obgyn core group, whose names are all mentioned here, and who have been the contributors to all the PPTs which you'll be witnessing today in this program. So, gender-based violence is the most pervasive yet least visible human right violation in the world. I mean, this is a fact, and that is why we all have gathered here to, throw some more light on it, so that we all are more aware about the topic. Now, through this presentation, you will actually come to know what forms of gender-based violence are experienced as women and girls, where can women and girls experience gender-based violence, and which age groups may experience the GBV. And meanwhile, I talk you through, you can put the responses in chat box for whatever knowledge about these questions you have till now. So, frankly speaking, the actual definition of violence against women as given by the UN Declaration is that it means any act of gender-based violence that results in or is likely to result in physical, sexual, or psychological harm or suffering to women, including threats of such acts, coercion, or arbitrary deprivation of liberty, whether occurring in public or in private life. So it's a comprehensive definition of all the aspects which we are going to talk about in the violence against women topic. So it is not limited to these factors, but it encompasses all of the most of the things which are included in violence against women. That is physical, sexual, and psychological violence, family aspects, community aspects, and perpetrated or condoned by the state wherever it occurs. Now, the types of violence which come under actually the gender-based violence are physical, psychological, sexual. They have been categorized under these three main headings. The physical violence includes kicking, biting, slapping, beating, strangling. Psychological violence includes preventing a woman from seeing family and friends, belittlement, humiliation, economic restrictions, violence or threats against cherished objects, other forms of controlling behaviors. Now, sexual violence, you all know, includes actually the sexual violence, forced sex using physical force, threats, intimidation, forced participation in degrading sexual acts, or denial of right to use the contraceptives. Mind you, this is also a form of sexual violence, or measures to protect against sexually transmitted disease. Now, intentionally inflicted injuries are often disguised as accidents. At times, women are seriously injured and in some cases even die as a result of their injuries. So this is not a matter to be neglected at all, and these aspects should be known to all the practitioners around. Now, on your screens, you can now see the prevalence of intimate partner violence given by WHO in 2010, and you can very well see that. Pardon me. Very well see that this region, our Southeast Asian region, has a good amount of figure. I mean, the largest amongst all, that is 37.7%. And overall, on an average, globally, the figures are 30%. Now, the IPV prevalence, which I said in the Southeast region, it includes physical and or sexual violence by an intimate partner in their lifetime. And amongst that, you can see where our India ranges. It's around 28.8% in India, whereas the other countries, as mentioned, with the figures are Maldives, Nepal, Pakistan, Sri Lanka, and highest being in Bangladesh. So, all these figures are just the tip of iceberg, because we all know, due to various reasons, the cases under gender-based violence are underreported. And the DHS survey data from 24 countries, which was collected from 2004 to 2011, suggests that 40% of women experiencing gender-based violence previously disclosed to someone, but only 7% reported to a formal source. And it also has regional variation, 2% in India and East Asia to 14% in Latin America and Caribbean countries. Now, this is the whole life cycle. So it is, the violence is not restricted to any particular age group of female. It starts as early as pre-birth. We all know female infanticides and, things like that. And from there, it goes through adolescent, girlhood, infancy, all the stages are affected. How? We'll just see, like sex selection, abortion, effect of battering on pregnancy and childbirth. So these are the pre-birth things. Then in infancy, infanticide, physical, sexual, psychological abuse. Then in girlhood, we see child marriages, female genital mutilation, physical, sexual, and psychological abuse, incest, child prostitution, pornography, all come under the ambit of gender-based violence. Adolescent age group sees trafficking, honor killings, partner violence, marital rape, dowry abuse, murders, abuse of women with disabilities, rape, sexual harassment, forced prostitution, pornography. So practically each and every of this, crime comes under gender-based violence. Forced pregnancy, acid throwing, date rape, economically coerced sex, incest, sexual abuse in the workplace, again, are included in gender-based violence. So 20% of women experience child sexual abuse. We must remember that. And also, globally, women were married before 18 years. 50% of child marriages occur in South Asia. We know that. 125 million women in 29 countries in Africa and Middle East experience female genital mutilation. So these are just figures, but as I said, so many things are underreported. And unless and until we have an eye to see what is happening around and how the patient is presenting to us or the female is presenting to us, the way we have to approach these things. Our next speaker will take you through this. So unless and until we are aware of all these things, we will fall short in approaching the gender-based violence comprehensively. So, so let us see what are the health impacts of gender-based violence on the individual. They can be grouped under physical or reproductive. Now, physical includes acute physical or chronic physical. Injury, shock, disease, infection, weight loss, regressive behaviors, not eating or eating all the time. Chronic would include disability, chronic pain, gastrointestinal disorders, eating disorders, sleep disorders, because, logically speaking, once a person goes through all this gender-based violence, she's emotionally, physiologically, every which way affected, which will eventually lead on to impacts on her health as well. Reproductive would be miscarriage, unwanted pregnancy, unsafe abortion, sexually transmitted infections, menstrual disorders, pregnancy complications, and gynecological disorders. So what we must understand as physicians is that the effect is not as such limited to the survivor per se, the victim or survivor, whichever way you call it. The recent terminology is survivor of violence. Effects are actually beyond that individual. So this can be on the children of the women who have experienced abuse. This can be effect on families, of course, because she's the most in our kind of society, she's the central person to hold on to the family. So when she's affected, in fact, the whole of the family would be affected. And effects on community and society. So what are these? Higher rates of infant mortality, behavior problems, anxiety, depression, poor school performance in adults and girls, physical injury or health complaints per se, experiencing or perpetrating violence as adults. They come on to the children of these females, maybe becoming on to, if they see violence all around, they tend to become perpetrators themselves. Effect on families would be like a fractured family relationship, safe care if abuse is happening in the home, housing instability, co-occurring violence, poorer collective health and coping. Effect on community and society, of course, at large, what would happen is that the cost of services incurred by victims and families would have a bearing on the health infrastructure of the country, loss of education and potential development, and contribution by child as they become adult. And of course, perpetuation of violence in the community, which is again a community hazard, and higher crime rates burden on safety and justice sectors. Now, how is this violence and HIV/AIDS intersect? How are they correlated at various interjections? Like, one thing we all know, there's a direct transmission through sexual violence, type of sexual exposure, presence of other sexually transmitted infection, which increases the likelihood of contracting HIV, and of course, the degree of trauma is related to the HIV and AIDS per se. Then second aspect would be indirect transmission through sexual risk taking, and violence is linked to increased risk taking with like multiple partners, non-primary partners. And of course, the third aspect would be indirect transmission through inability to negotiate condom use, which I said earlier on that it's again a type of violence, and women find it difficult to suggest or insist on condom use in face of threat or violence. So this is, a comprehensive flow chart about the various aspects of intimate partner violence and its effects. Like, it can be physical trauma, as I said, psychological trauma, and fear and control. So these, as you can see, are all interrelated. Once you have a physical trauma, injury like musculoskeletal, soft tissue, genital trauma, and this would eventually lead on to mental health problems, which are again directly related to the psychological trauma as well, like PTSD, post stress disorder, post injury, or post what you call, once the event has occurred, after that the effects come. Anxiety, depression, eating disorders, suicidality, substance use, alcohol, other drugs, or tobacco, and they eventually lead on to non-communicable diseases like cardiovascular problems and hypertension and other somatoformic disorders. Then fear and control are also interrelated with the mental health problems which I've just described. And other things, other effects of fear and control would be limited sexual and reproductive control, like, lack of contraception, unsafe sex, and healthcare seeking behavior may be affected. Females feel like having a lack of autonomy, difficulty seeking care and other services, and eventually it will have effect on perinatal maternal health, and of course sexual and reproductive health as well. So 42% of women who have experienced this kind of physical and sexual violence at hands of a partner have experienced injuries as a result. So we all must understand this. And in fact, their mental health has been twice as likely to be affected, and they have been into depression. These are all the facts which have come out of the studies done world over, and almost twice as likely they are likely to be having substance abuse. 16% are more likely to have a low birth baby. As I said, there are perinatal and maternal health issues as well, and twice as likely to have abortion. 1.5 times are more likely to acquire HIV, and 1.5 times more likely to contract STIs like syphilis, chlamydia, or gonorrhea. 38% of all murders of women globally were reported as being committed by their intimate partners. So, no place is actually safe for women. 4.5 times as likely to attempt suicide. And after having this overview, let us take you through some quiz questions. Let us see what you answer in the chat box. So the statement is intimate partner violence is more prevalent among poor women and girls. Can I have the audience poll on this, or audience opinion on this? Is it right or is it wrong? No. I saw one no.
No.
Anybody else?
No.
Right. So it is a myth. And studies show that gender-based violence can happen among people of all socioeconomic, educational, and racial backgrounds. Violence may affect our peers, colleagues, and friends. So ideally, we have to keep our eyes, nose, ears, everything open for finding, such victims if they present to us. And no particular sect is safe from experiencing gender-based violence. Now, let's have another statement. I'm so sorry. We can't go back. I'm really sorry. So this is the statement. Something is happening, skipping the slides. Okay. This statement you can anyway see on your screen. When it is not severe, beating by husband can be if the wife is acting inappropriately, which is a myth. Gender-based violence is a serious human right, health and development issue impacting the survivors, their families, and the health and development of entire communities. I'm sorry, I couldn't ask you to answer it over it. I don't know, my screen is not able to remove this chat. Okay, let's see the next statement. Are you all able to see the screen properly?
Yes, ma'am.
Yes.
Because somehow my screen is getting obstructed because with the chat window, which I just opened to see your responses. Anyways, so let's go on to the next statement. Majority of violence against women and girls is perpetrated by strangers. Is it a myth or a fact? Myth. Yes, Dr. Pratima. Anybody else? Okay, so I guess we have a fair bit of an idea. Yes, studies have suggested that most women who experience sexual violence and are abused by people they know, often the perpetrators are those they trust and love. And globally, women's homicides are 6 times more likely than men's to be committed by an intimate partner. So everybody needs to be wary of this fact. Okay, is it safer for a woman to be out of relationship with an abuser than to stay in the relationship? Is it a myth or a fact? Great, Dr. Pratima. Anybody else? Any other view? Fact, Dr. Jayashree. Fact, Dr. Yasmin. Well, yes, that is why this statement is very interesting, and we also really found it very interesting when we were going through our training of trainers program, because we realized that it is actually a myth. Emotionally, we would feel connect with this female, and we would think that it's better that they are out of this relationship. But frankly speaking, the figures have shown that the violence after they get apart may increase when she leaves the partner. In fact, a woman's risk of being murdered is greatest immediately after separation. So this was an eye-opener statement even for us, and probably from now on for all of you who are attending this program. So this is the eventual crux of our presentation, that yes, it is a very important thing, gender-based violence, and it affects in all aspects the health and development of the survivors and their families, and health and development of the entire community eventually. So one thing which probably Mr. Ajay forgot was to tell you, though you must have entered a form while getting registered for this program, which was a pre-test. And now I would request you to, before leaving this meeting as a whole, you have to fill the post-test as well, because that will be required to be, by the Foxy team, and you will be provided certificate in accordance with that. And so you must complete the pre-test, post-test, and the feedback. So I now invite the next speaker, Is it Dr. Rachna?
I'm Prevalence.
So with that, I finish my topic and I invite the next speaker, Dr. Meeta or Dr. Prema.
Prema, ma'am.
Okay. So Dr. Prema, please take them through the next important topic of approaching the gender-based violence.
Thank you, ma'am. Thank you for your elaborate discussion on gender-based violence, ma'am. So I'll share the next slide. Shriman, sir, can you make me co-host? I'm not able to share the slide.
I made you co-host, madam.
Okay, sir, I'll share. Is my slides visible, sir?
Yes, they are visible.
Okay, thank you. So the next module is on how to approach a woman facing violence. So why do survivors not seek help? It is mainly because of the victim blaming attitudes of the providers, fear of shame or stigma, fear of no confidentiality, inappropriate services or services that are not useful or prioritized by the survivor, perceived impunity of perpetrators. Is there any other reasons? Please put your comments on the chat box. So who can play a role to help the survivors and how? Everyone, including family, friends, community, service healthcare provider has a role to play for the survivors. So the role of family, friends, and community includes the recovery from the violence dependent mainly on the extent of support received from the loved ones. Health professionals engage with family and discuss ways of promoting survivors' well-being. It should be discussed with all caregivers that survivor should not be held responsible for the assault. In case of child sexual abuse, parents may experience anger, confusion, guilt, or self-blame. Reiterate that it is a perpetrator who misused their position or not themselves. So all women are likely to seek health services at some point in their life. Healthcare providers are often trusted by the woman and they serve as a role models in the community. Violence is an underlying cause of injury and ill health. So it's a responsibility of the healthcare providers to create an enabling atmosphere and establish the trust of the survivor. How? Speak to the survivor in a private space. Recognize her courage in reaching you as they have overcome several barriers. Recognize the dilemma faced by the survivor in reporting the violence. Do not label the non-reporting to police as false case. Assure the survivor that the treatment will not be compromised. Inform the survivor of the available resources or legal rights so that they can make an informed decision. Coming to the facilitation and demystification of the medical procedures, the health professional should prepare the survivor for that internal examination. Explain the various stages of examination and communicate the rationale for referring to the X-ray, ultrasound, age estimation among the other investigations. Recognize the survivors may present varied emotions. Encourage the survivors to express their feelings, to seek crisis counseling, assess for suicidal ideation, make a safety assessment and safety plan. Involve family and friends in the healing process of the survivor. So what you can say, instead of asking, tell me what happened, you can tell like, take your time, share only what you would like to share. I can imagine that it must be really hard. It takes a tremendous amount of strength to share what is happening to you. How do you think we can help you? You're not alone. Coming to the practical approaches, one is solar approach, which means sitting position, open posture, leaning forward, eye contact, and a relaxed position approach the survivor. Coming to supporting gender-based violence survivors using the lives approach, it includes listen, inquire, validate, enhance safety and security. Once again, sorry. Can you see my slides?
Yes, ma'am. Yes, ma'am.
Okay, sir. So coming to the listen approach, listen with your eyes, give her your undivided attention. Listen with your ears, hear her concerns, and with caring and respect heart. Use verbal and non-verbal means to show support and communicate understanding. Ask mostly open-ended and focused questions rather than closed questions. Use good body language such as good posture and eye contact. Avoid leading questions and compound questions. There are certain do's and don'ts when you approach listening. So how you act, be patient and calm. Let the client tell their story at their own pace. Let her know you're listening through verbal and non-verbal cues. For example, nod your head or say, Maintain gentle and appropriate eye contact. Acknowledge how she is feeling. Give her the opportunity to say what she wants. Ask, how can we help you? Encourage her to keep talking if she wishes. Ask, would you like to tell me more? There are some don'ts, such as don't pressurize her to tell a story. Don't look at your watch or speak too rapidly. Don't answer the telephone or look at the computer or write something else. Don't judge what she has or has not done or how she is feeling. Don't say you shouldn't feel the way or you should feel lucky to survive.
मला कॉफी सांगितलं आणि आता फोन वाजवू नका, काय असेल तर आतमध्ये येऊन सांगितलं किंवा चिठ्ठीवर लिहिलं तरी चालेल.
Ma'am? Ma'am, shall I proceed? Is my screen visible? Is it audible? Shall I proceed, ma'am?
Yes.
Yes. So don't assume that you know what is best for her. Don't interrupt. Wait until she has finished before asking the questions. There are certain do's which includes allow for silence. Give her time to think. Stay focused on her experience and on offering support. Acknowledge what she wants and respects her wishes. The don'ts includes don't try to finish her thoughts for her. Don't tell her about someone else's story or talk about your own troubles. Don't think and act as if you must solve her problems for her. Inquire about the needs and concerns. So how do you act? Phrase your questions as invitation to speak, mainly open-ended questions, instead of the closed questions such as yes or no. Check your understanding by restating what she says. Reflect back to the client the feelings they express. Explore as needed. Ask for clarification if you really don't understand. Help her to identify and express her needs and concerns. Finally, sum up what she has expressed. So, as I mentioned before, you could approach like, what would you like to talk about? How do you feel about that? You mentioned that you feel very frustrated. It sounds as if you're feeling angry about that. Could you tell me more about that? Can you explain that again, please? Is there anything you need or concerned about? You seem to be saying that. So, validate does not mean try to verify the survivor's story. For example, through interviewing the alleged perpetrator or the witness. This is not safe, appropriate, ethical, or recommended. Show her that you understand and believe. Say it's not your fault. You're not to be blamed. You did the most important thing you could do in that moment. No one deserves to be hit by their partner. You're not alone. Unfortunately, many others face this problem. What happened has no justification or excuse. Your life, your health, you are of value. Everybody deserves to feel safe at home. I'm worried that this might be affecting your health. It's okay to talk. So approach in these ways. So coming to the sympathy versus empathy. Sympathy means it is personal, emotional identification with the survivor's experience and implies the service provider feels sorry for the survivor. It is an emotional state that leaves a service provider vulnerable to over-involvement and can take power away from the survivor. It is identifying the survivor's experience through your own shoes. Empathy is what needed, and it implies intellectual or personal understanding and realistic or professional distance. It involves compassion and objectivity and leaves room for empowerment of the survivor. That is an attempt to put oneself in the survivor's shoes. So coming to the dealing with emergency situations using life's approach. So there are some challenging situations when dealing with a survivor who is in immediate danger. So if the survivor tells you that the abuser has threatened to harm them, what should you do? Please put your thoughts in the chat box. So a few ideas include ask concrete questions about the safety risk, but only when there is privacy. Ask if the survivor has a safety plan in place in case she needs to flee. Discuss the potential strategies for being able to leave a situation safely. Provide a referral to gender-based violence expert agency for additional help if possible. Here, as a provider, it is not your sole responsibility. When a survivor expresses suicidality, there are some challenging issues. So be able to recognize the signs of depression and suicide risk. Do not be afraid to ask, are you having thoughts of suicide? If the answer is yes, then take it seriously. Do not leave the suicidal survivor alone if there is immediate danger. Always consult your supervisor about how to refer or manage a suicidal survivor. Never make a decision on your own. This is for your own safety and well-being. Provide a referral to a gender-based violence expert agency for additional help if possible. Again, I want to highlight, as a provider, it is not your sole responsibility. Suppose if you ignore the violence, it can be more harmful. There are some possible behaviors and possible consequences. So if you blame or disrespect women or girls, what happens? It inflicts additional emotional stress or trauma to them. If you didn't recognize the gender-based violence behind chronic or recurring conditions, the woman receives inappropriate or inadequate medical care. If you fail to provide post-rape care or address gender-based violence in case of family planning or sexually transmitted infection or HIV care, that will lead to unwanted pregnancies, sexually transmitted infections, HIV, unsafe abortions, and even more violence. If you breach privacy or confidentiality, then the partner or the family member becomes more violent if they overhear the information. If you ignore the signs of fear or emotional distress, then the woman may later get injured, killed, or even commit suicides. So tell the woman that you may be his excuse, but you are never the reason for his violence. Women are not responsible for men's violence. Warm referral practices help women to reach further care. So these are some helplines, linkages. If the survivor will reach out to someone she trusts, it could be a family member, friend, or healthcare provider. Then she should be subjected to medical examination to provide emergency contraception care, PEP, or STI testing and treatment services. Then she should be provided emotional, psychological support, legal advice, then provide security and safety. So I would like to remind you that at the end of this session overall, there'll be postage and feedback link. Only after fulfilling all this, you'll be able to receive the certificate. Thank you.
Yes, Dr. Prema, that was a very nice presentation. Thank you. And that was a very important point that you got to all of us, that as gynecologists, we are service providers, but then we are not solely responsible, and we need to also, go into an empathetic position where that empathy is important, and where we need to, help the survivor to move on their own. If we cannot take up all the responsibility for them, but yes, I mean, it is equally important for us to pick it up. Very nice presentation. Thank you so much, Dr. Prema.
Thank you, ma'am.
Yeah. So are we having any questions on this, or shall we move to my presentation? I guess we can move to the next presentation. Can I share my screen?
Yes, ma'am.
Yeah, I'll
Then
go ahead
continue.
with that. So
Yes,
our
ma'am.
next topic is going to be on effects of VOW on pregnancy and newborn. So I hope my slides are seen by everyone.
Yes, ma'am.
Yeah. So fine, as gynecologist, when we are training now for obstetricians and gynecologists, and this is a training for our Dheera program for OBGYN. So as we all know, we are already working on this. We are seeing patients, and we really need to discuss now what is the effects of VOW on pregnancy and newborn. That is what is going to be our primary intention about this presentation. Can I just minimize this? Yeah. So as we know that as far as maternal death is concerned, there are a number of causes which is responsible for maternal death. Of course, we see that 90% of them are avoidable, and interestingly, 60% occur in the postpartum period. 50% occur in the first 24 hours. Now, we go by the WHO report of 2005, severe bleeding, infections, eclampsia, obstructed labor, unsafe abortion, and so many other causes that we see as the causes of maternal death. But we must see that, yes, there is something behind this as well. And what is behind these causes? It's not always only a pathology, but there is something more to the whole story. And there we need to go into the details of whether there has been any incidence of violence. So there is a very high incidence of violence during pregnancy. And so we need to know and we need to address that issue as well. So we have a few case studies where the first case was of a primary. She came with premature rupture of membranes, and then she went into prolonged obstructed labor, then and finally presented with rupture uterus and shock and maternal death. Now, when the history was actually probed into, it later revealed that there was history of brutal kicking on the abdomen by the husband, and she had violently fallen on a sharp edge, and actually the death was due to violence and not more due to an obstetric cause. Coming to the second case, where there was a gravida 3 para 2 living to 28 weeks with previous 2 LSCS, patient came with bleeding, antepartum hemorrhage and shock, and placenta accreta was diagnosed, hysterectomy was done. It involved a number of blood transfusions, bladder involvement, but at 28 weeks she was bleeding. So what was it that precipitated this bleeding? And it was not a spontaneous bleed, but it was a history where there was a history of violence. That was, she had husband had kicked her on the abdomen, and that was one of the reasons why she went into this bleeding or APH. Similarly, a woman with preeclampsia found unconscious, and she had a cerebrovascular accident and a maternal mortality. So the report was death due to eclampsia. But there was something more to the story. Actually, she had a violence. She had faced violence, and there was a fractured skull and cerebral hemorrhage, and this had actually caused the death. So the eclampsia was actually an indirect cause, and a direct cause was some kind of trauma that she had undergone. So hidden violence is masquerading as a maternal disorder, and in fact, amongst the preventable causes of maternal mortality, violence is forming one of the most important. Another case where a gravida 3 para 2 living to with previous to LSCS full term, and she had a previous history of a rod implanted because of a fracture of a femur or hip joint, and she suddenly collapsed in front of a hotel, and she was brought to the emergency in active labor with severe hypertension, and an emergency LSCS was done, and this patient had been pushed from the second floor a few years ago, and now she had been abandoned in labor. So we are seeing that, you know, patients coming to us, sometimes we only look at the obstetric part of it, only the medical part of it, but there is some, hello? So there is something more in the history that, you know, we need to really probe into, or at least we should be sensitized enough to look into that there is something more to the whole incidents that has occurred. So gravida 3 para 2 living 0 with 2 previous LSCS. She came with 36 weeks with severe anemia, and and she had lost her earlier babies, and both the time she had history of physical violence, and that is why she had two intrauterine deaths. Third pregnancy, parents brought her home, and then she had to be given blood, and LSCS was done, and she did deliver a live baby. Similarly, we have a gravida 6 where she had 2 living issues, previous 3 abortions, brought with acute hemorrhagic shock and incomplete abortion. So severe form of physical emotional violence and forced abortions was there, and this brought out that this history was important where domestic violence, it came out only after the history was probed into. So there was another case where we have a stab injury by the husband and causing lacerations on the face and perforation of the uterus, and where the laparotomy was done to repair the tear that was there on the uterus. So when we are going through these cases, what it definitely pains to see that women coming to our clinics and where we are missing something which can be tackled to some extent. And so as an obstetrician and a gynecologist, we are stakeholders in women's health and in a very unique position, because patients come to us, they confide into us, and we form we can assess and provide support for women because of this very unique nature of a patient-physician relationship that we share with our patients. So because we have many opportunities where we can intervene during adolescence, pregnancy, family planning, annual examination, other women health visits. Sometimes in the pandemic, we have seen patients who have come to the clinic without any history, any gynec complaint, just to move out of the house. As we all know that COVID has been a time when this silent pandemic of violence has increased rapidly and grown to a major extent. So where women were confined to homes and they didn't know what to do, and so we've had a history of women coming to the hospital or visiting the gynecologist just for some help as far as this was concerned. And so we form a very important part in their lives where we are going to help them. So how do we go about this? So like Dr. Prema and our earlier speakers have said, that we have to go through indirect questions. We don't have to actually, investigate very pokingly, but yes, it has to be an indirect question, which could be a very casual question like, is everything okay at home? Are you okay with your partner? All these very simple things, but sometimes patient just wants that, like an icebreaker to start that this is gone wrong with me and I want to talk to somebody. And sometimes talking to somebody also makes them feel comfortable and probably gives them an insight into their issue, whatever they are facing. Now coming to there are some few screening tools that are available, like the abuse assessment screen, the HARC screen, the HIT screen, and ongoing abuse screen. There are a lot of assessment tools also. Then the partner violence screen. Then you have the VAS screen, where women abuse screen tool is also there, and the women's experience with battering scale. Now all these screening tools are available, that is that can be made available for screening of these women who are facing partner violence. Now, the WHO in 2018 has recommended that all health professionals should be trained in first-line response to family violence. And like she very nicely put it, my earlier speaker, about lives, and that is listen, believe, inquire, validate the person's experience, and enhance the safety, and offer ongoing support without being judgmental. Many times, women are not ready to open up because they feel they will be judged, or some moral sticks are going to be applied to them, and we're not going to listen to them. So it's important that we should offer support and enhance the safety of the woman who is coming to us. Universal screening or routine inquiry about IPV is not recommended. However, WHO guidelines identify ANC as a setting where routine inquiry could be implemented if providers are well trained, and that is very important in today's training. What are we actually going ahead with this? See, all of us see patients, but why is this training? The training is because we want the providers to be trained well as to how this inquiry has to be taken forward and how the patient has to be counseled and what kind of help that we are going to offer. So we are going to train OBGYNs for this we are training OBGYNs for this kind of a interview of the patient when she is in the clinic, and so that they are well trained on a first line response and at least the minimum requirements are met. So when we are ensuring safety, the evidence on benefits and potential harms of clinical inquiry and subsequent intervention is lacking or it's uncertain. But a minimum condition for healthcare workers to ask whether is that about violence is safe, and identification of this intimate partner violence is followed by an appropriate response. And there are a lot of guidelines, and these guidelines can be found on the WHO website as to how this response to IPV and sexual violence should be. So I would request all the participants today to go through the pre-test and post-test, and please submit your responses, because only when you submit your response that your certificate is going to get generated. So please make it a point to address your post-test as well and your feedback, because the feedback is going to help us to improve this program day by day, because this is such an important and sensitive issue that it is going to go on for this is something which has to be addressed for years to come. So very nice words by Anasuya Gupta, where many women in many parts of the world speak the same language, but the language of silence, it is something where these victims or survivors of violence always want to take up, and it is up to us obstetricians and gynecologists to be the voice of the silent victim. So I think I have come to the end of my talk on effect on pregnancy and newborn, why it is important and how we are going to, we all know what kind of effects it's going to have. We are going to have FGR babies, we are going to have SGA babies, we are having preterm labor, but all our obstetric causes, when we are suspecting, we need to just see whether there is any history or any possibility of a violence that, that we have missed. So if there are no questions, we can move on, or if there's anybody would like to add anything to this talk. Can we move on to the mental health effects of violence here then? Anybody who want to ask any question or want to add to this? But see, all the participants, we want your active participation. It is, if you have any questions, if you have any suggestions, you want to share something, please do so, because this is not, it is a virtual program, but ideally it would have been on a one-to-one interaction. So if there is anything that you would like to discuss, or you would like to, add anything, that will be really nice. I mean, it'll be more of an interaction, because we all are at par, we all see patients. So is there anybody who would like to add something, or from the panel today who's speaking, anybody would like to give any inputs? Okay, so then I'll move on to my next presentation.
Yes, ma'am.
Yeah, so the next presentation will be on, give me a minute. Give me a minute, just a minute, okay? So. Yeah. So we move on to the next. I think my presentation is visible and I'm audible, I hope.
Yes, ma'am.
Yeah,
Yes.
thank you so much for giving the okay. So thanks. So we move on to the mental health issues, that is about women who have suffered the violence. I mean, once again, we would like to thank the whole team who has put a lot of efforts in preparing these slides and getting the material together, and Mr. Ajay Bharadwaj, Dr. Kiran Mai, and Dr. Ramani Devi, Dr. Deepa, and of course our president, Dr. Shanta Kumari, who has brought us such an important topic on the to the surface for all of us gynecologists who are practicing in this country. So we'll move on to the mental health issues about women who have suffered violence. Again, we have a case report where a 26-year-old woman was brought to the hospital, and she came with sudden complaints of pain, and she had been married for a year, and she was a primigravida, 28 weeks pregnant, and regular patient, regular checkups, no high risk, no hypertension, no diabetes. And on examination, she looked very low and she was depressed, and she would answer in mono words, and her vitals were normal, uterus was 28 weeks, fetal heart was normal, irritable kind of a uterus, and vaginal examination, there was nothing really which was specific. Now this is a very typical patient who would come to us, who you can make out, like the body language is so important when we are seeing our patients, something which AI or maybe any kind of virtual platform might not even give us this kind of a clue that this patient has come for has faced violence. But when she's coming to our clinic and she's walking in, her body language is very important. And there she, on inquiry, she came out with a history that she was beaten by her husband. Now, what details do we need to gather from the patient? Whether we need to inform the police, how to counsel her, what are the problems that this patient can come across, family counseling, any drugs, or what are the aftermaths of this intimate partner violence. So when we are talking about this, it is important that we must realize that, yes, what are the details to be gathered? Like in the earlier presentations, my two earlier speakers have spoken about what details we need to gather. But yeah, like we cannot be too much, we can't provoke any questions, but yes, I mean, we can gather history of any violence and whether how comfortable she is to inform the police. And we cannot force it on somebody to inform the police, but yes, we can always assist her. Okay, and we need to counsel the patient, make her aware that yes, I mean, this is a kind of violence and which can cause injury to her baby and to herself, and what problems that she can undergo. So this, like we can see, is not only a job of a gynecologist or an obstetrician, but yes, we need a triad of consultations with the psychologist and the psychiatrist, and where it will be really nice if we could involve them also in our team. Now, why mental support is needed, even if she has faced violence at any point of time, it is, like I said in my earlier presentation, that we are the first line in OBGYN where we encounter our patients at multiple levels, right from when they're young girls to their pregnancy, the prenatal counseling, the postnatal counseling, the contraception, their gynec problems and everything. And sometimes, like I said, no reason, they just want to see a doctor and they feel that they can come and confide in you, or they look at you as a person who can give them some support. And there is where we should be coming in. So why do we need this mental support? So the most important is post-traumatic stress disorder, where this disorder can lead to can cause life threats or injuries. So it is important to be vigilant on that. Also, mood disorders like depression, suicide, substance abuse, sexual disorders, phobias. They can also have functional GI symptoms like irritable bowel syndrome kind of a thing, dissociation symptoms, and commonly they go into social withdrawal. So it is important that these conditions, mental support is made available to them. So as an obstetrician, what are we going to do? We can assess the risk. That is what is the frequency? When we are gathering the information, we should know what is the frequency. Was it just a single event, or it has been there for some time, or it has been coming at regular intervals, and how severe it has been, whether it has ever been a threat to her life or to her baby's life at any point of time. Then what if there is a history of assault or history of violence? It's not always only physical violence. When we're talking about violence, let's understand that yes, physical violence, emotional violence, financial manipulation, sexual violence, everything is a part of violence. So we're not only looking for signs of injury, we're looking for signs of all kinds of trauma. So as a risk assessment would involve frequency, severity, and chronicity of the type of trauma that has been inflicted on the person. Along with that, now that we know that there has been a history of violence, we want to look at the safety. That is to prevent from further assault from the partner, and also any risk of suicide or any danger, and so psychological screening, and also to assess whether there is any possibility that there is a homicide risk from the information and from the history and from the conversation that we are going to encounter with these women. So the danger signs would be a frequent kind of acts of violence, presence of any severe injuries, alcohol misuse, threatening to kill, sexual violence. Now, very, very commonly is that we don't expect intimate partner violence is not considered by many as a sexual violence. Intimate partner violence is also a sexual violence, and that is something which women are not ready to accept, or they feel it is it's normal to have sexual violence by the partner. Then suicidal suicidal ideation in women, access to weapons, or morbid jealousy in the partner. All these could be just a danger sign that this lady needs some help. So when are we going to hospitalize these women? Any person obviously with any severe medical injuries or any severe obstetric complications related to this kind of a history of violence, we are definitely going to admit. Any tendency of suicide, a possibility of a homicide, or any dissociative or psychotic symptoms, any mood instability, self-destructive or inflictive behaviors, serious threat, anywhere we are seeing that yes, this is likely to cause a threat to the patient's life, here we are coming in that we can just hospitalize the patient. Once a patient is hospitalized, she's at least, we are preventing further damage or further injury to her, and that is where as an obstetrician we can help her. Again, it's important to know that this treatment or this plan cannot be an individual. It has to be a multidisciplinary treatment where we are getting into account the obstetrician, the psychiatrist, the psychologist, the social service provider, and also we are going to assess the whole risk, and also give us, along with mood stabilization, need to evaluate what kind of medication she can take, the psychosocial support that we can give her, and important to also in the need for the rape kit is if there is any sexual violence, photo documentation, and we need to report if there is any legal concern. Now the question is that again, without the consent of the woman, we cannot go and report to the police, and any documentation that has to be shared cannot be shared without her consent. So her consent is very important when you want to share any documents with any legal or social worker. So that is very important from our safety point of view as well. So like in NIMHANS, they have a trauma recovery clinic. Similarly, such kind of clinics for these women can be put up in maybe in a city, or maybe have 3 or 4 in a big city where women can actually go to this recovery clinic and they can come to term with trauma. They can which can reduce the emotional symptoms of trauma, enhance their self-esteem and resilience, and prevent re-traumatization. Now there was a very interesting talk about violence against women that I came across, and why women have to we need to address them, because when we see that it is not only about these women, it is also about the children and the family who are witnessing this whole thing. And then we have children who they will either, when they grow up, are going to either support this violence, or they are going to fight against the violence or get indifferent to it. So we want that the next generation to come has to also refrain from all this kind of behavior, and that is why it is important that social support is given to these women, and we need to conduct awareness and capacity building programs for psychologists and counselors, because they also need to be sensitized to look at this as an important subject. So we can have such clinics in any multidisciplinary centers, and that is now getting us to be the need of the hour. Now, so psychosocial impact of VOW is feeling of helplessness, progressive erosion of confidence and self-esteem, feeling of guilt, shame, isolation, then traumatic bonding, physical separation due to increased risk of homicide, and it also decreases the ability of the victims to cope up with life. So role of a psychologist is very important, and post-assault psychotherapy or CBT, or even you have MBTFC, all these are all these therapies that are involved with that are conducted by the psychologist are important, and they can accelerate the recovery of victim in acute cases. Now, this is a STAIR, that is a skills training in effective and interpersonal regulation. This treatment includes recognition of achievements during treatment and exercises in self-compassion, along with all this, that is a psychoeducation about the impact of trauma on emotion and relationships, emotion regulation skills, effective expression of negative emotions, interpersonal skills, and development of flexibility. Because we are not trying to tell the patient that you leave your house and you can just come, you can just quit your family or something. We have to give them coping skills as well. So when we are giving the coping skills and we are helping them with coping skills, we have to give them different options, and the psychologist is going to really play an important role. So interpersonal psychotherapy, it has been shown to be effective. non-exposure based treatment for post-traumatic stress disorders, and many PTSD symptoms reflect interpersonal difficulties like emotional withdrawal from relationships and individuals' interpersonal deficits, sometimes which result in interpersonal hypervigilance. So it's important that IPT also plays an important role. Other newer psychotherapies include CPT, EMDR, HOPE, and RPRS. I think as obstetricians, it is best that we hand over to the psychotherapist, but we should know that yes, these kind of treatments are available and they should be made available to them. Psychological therapy, women who experience IPV-related depressive disorder or alcohol disorder should receive mental health care as per the WHO guidelines of 2010. And this is very important that it has to be delivered by healthcare professionals, not only delivered, but it has to be delivered with good understanding. And there is where, our being sensitized and by an understanding of our subject is considered. So CBT and EMDR interventions delivered by healthcare professionals with good understanding are recommended for women who are no longer experiencing violence and suffering from PTSD. So we have to understand it is not only about the time when she has come and she's faced violence. It's a little long way to go, and it needs regular follow-up of this woman, and to help her with PTSD as well, that is post-traumatic stress disorder. Now, what are the WHO recommendations for these emotionally or medically unexplained complaints? As far as antidepressants and benzodiazepines are concerned, for a mild phase, you can avoid. Moderate to severe depressions, tricyclic antidepressants or fluoxetine can be used. In absence of prior depressive episodes, then initially we will not be actually going for any drug treatment, but they can be continued safely from 9 to 12 months after recovery. And a brief structured psychological intervention in the form of cognitive behavioral therapy or IPT can be also instituted for the woman. Then relaxation training and physical activity for a de-stressing event, for de-stressing herself, and psychological support after a recent traumatic event, that is mainly about psychological debriefing. Psychological debriefing also forms a very important and a very significant part of treatment, where it really helps them to cope up with their trauma or the stress that they've undergone, and of course first aid in case of acute distress. Okay, this important also to address the partner, that is men, group treatment therapy, where they take personal responsibilities for violent behavior, challenge attitudes and belief around the use of violence in a relationship, and developing skills for reacting non-violently to others, and increase the awareness of dynamics used in violence. Now, again, here we need to understand that when we're talking about violence, it is not only physical abuse, it means abuse in all kinds of fashion. So mental health, now that we have been discussing VOW, we know that VOW is not only about physical injury, it is a big toll on the mental health, and it is an issue which is where these women are affected, and it needs to be addressed along with the physical health. So once more, requesting everyone to please post your post tests also, and to give your feedback. And after these two talks, I think we will invite some questions or some suggestions or something, whatever you feel about what we have been talking in the last 4 talks, just a feedback from those who have joined us. So it will help us to understand, whether we are on the right track. So anybody who would like to give their views or want to add on something, I would be very happy if you could do that. Anyone who's here?
Yeah, we should have good evening, and that was a wonderful session. And I feel that every association should form places where these people, when we come across, have to be handed over or reported, because we cannot be handling them. We can just find out if there is any problem with them. But only thing later on, what to do is the next big question, whether we cannot be handling them for lifelong. So you have to have some place where they have to be reported to, and they will be taken care of. So every association, of OG has to form places where they can be informed. That has to be informed to everybody. See, because I being in Trichy, it's not enough if I know in Trichy alone. if I come to know about somebody in Chennai or in Salem or Erode, we should know where to hand over them.
Yes, ma'am. I totally agree with you, ma'am, because the most common problem is like that we should know what next. You know, it's not only enough that we pick it up, but like we have put up that it is a mental health problem, it is a social problem. So we should know who is the person or what is the, we should all have one team, maybe per society, like you said, where the team comes together when anything that they encounter, it is handed over to the team and the team effectively takes over. Most of the times it like these women, I mean, from not now, but I would say around 5 years back, I had a patient who came with history of violence. And, you know, when I had handed over this case to a women organization. So, you know, the first thing that she said, ma'am, they're so judgmental. The moment you go there, they look at you at in a very wrong fashion. They don't want to help. They just want to, you know, they toss the phone calls also. So it's not easy. I mean, we have picked it up. What next? And like Dr. Jayashree ma'am has really correctly pointed out that just picking up would not complete the whole process. We need to, you know, move forward and form teams in each society about it. So thank you, Jayashree ma'am, for that wonderful input. And I think, you know, the next step after this training should be, you know, to get these teams in place. Society by society.
And one more thing I'd like to, like all the members who are joining this Dheera group to know is, you should be careful about your own safety about it. See, when somebody is up to infringing violence on a woman, we are also women. So, so that person will get irritated that his wife or his sister or whoever he has abused is made to expose her problem, and if we are going to bring out the his identity, then these people will get furious about it. So we should also equally be behind the screens and do the work.
Yeah, so finally it's a teamwork, I guess, where they will have a social organization who will be the face of the whole thing. And when we have the society could be the face of the whole thing, it cannot be an individual person who will be, you know, actually dealing with this. And it has to be on behalf of an organization. Like you said, we have to look after our own safety. And in a little patriarchal society, we need to see that, you know, even our safety is not at stake. And that's a very important recommendation that you have given, that is important. But equally important is that like Dr. Prema has said, that we cannot cross our boundaries. Like, you know, we need to know where our boundaries end, but yeah, at the same time we need to offer help. So it's at the moment looks little superficial. We've not actually come to the end of the tunnel, I guess. There is one question that I think all of us should know whom to report in our city, but it's a fact that women don't like to report. What to do? So, ma'am, would you like to address this? One thing is that if the woman does not want to address, does not want to report, we cannot force her. We can only make her aware about what is available, what help she can take, and what are the possible resources and why she should take. Because, like, you know, in our school programs also, we have put it that this violence is a vicious cycle. After some days, you know, the partner will be fine, they will be, you know, everything will be happy, and after some time it is going to come in it goes on in cycles. So this is not one incidence and then it is done. It is likely to repeat. So she should know that yes, this vicious cycle of repetition of the violence and happy moments will continue, and she needs to develop either her own skills or she needs to stand up. So either of them, you know, that she has this options of choosing, or she has, there is something available for help. It's not as easy as it seems like, but yeah, there is, at least there can be a beginning to this whole thing. Anybody would like to add anything? Dr. Yasmin?
Yeah, I'm going to speak on that safety of ourselves also, but here, as you are telling that if patient is not agree, we cannot force her, because we have to respect her wish, but we have to tell her that first she will work over her safety and her children also, because the violence may be transferred to the children also. So that is the one thing is there, that we make aware the patient only. And as madam told, that we are not sole responsible for all things. So we have to sensitize the people around her also. So they should do something for her also. That is, the people living in the same house, they should also stand up for herself, for her also. That I think it's better in the family.
There is one more question about, should we mention episodes of VOW in our OPD papers to save us medico-legally, especially in case of suicidal ideation?
Oh, God.
No, if a patient is giving you a history of suicidal tendencies, it is important to mention that, I guess, that yes, she has given us a history of something like similar, but equally important it is when she's giving you history that, you know, she has this feeling of suicide, it is important that you should also mention in a paper that you have referred her to a psychiatrist, and whatever counseling you have done, and probably, you know, you can have a family member who comes in and who has been effectively counseled that yes, this woman is, you know, going into this, because finally we want to help her in a very I would say keeping our safety. Plus at the moment, if she has come and told us that she wants to commit suicide and tomorrow she really does it, it's going to be you can't just mention that suicidal tendencies, but you need to also mention what kind of help you have offered to her, and see that, you know, that some kind of help is given to her.
It's not better that we will write to the referral for her rather than writing that she has a suicidal tendency, because if husband can read, then that is a problem for her. Then she cannot reach for someone. If we will document this in our
I think that
paper.
what they meant was to keep it in our own record rather than giving it to the patient.
Yeah, that is the one thing that we can keep in our record. That is a ghost for her, but we cannot write on the handle notes what is she is taking with her.
Yeah, or at the most, you know, we can have, like we have said, that this patient can be hospitalized for some reason, and then, you know, call in a psychiatrist and then put it on paper and, you know, help her in that way, because that is one of our indications where we have said that you can admit these patients because they need hospitalization. When a person is going for suicidal tendency, it is a sign of major depression, and major depression definitely needs to get definitely can seek admission. So I guess admission and then, you know, mentioning and taking help would be a better option rather than putting her back into that same family environment where she goes home.
Yes, definitely. I agree with Dr. Gauri. And, suicidal ideation is not a small thing. We as practitioners must pay heed to this. And, you know, if the female has been strong enough, vehement enough to come out with actually this thing, and you are able to elicit it out, that it becomes our prerogative to actually help her out, you know, in every possible way. And, find next of her, best of her kin whom she confides into, and, to save her from that environment. Whatever has led her to go to such a typical tendency, it is not good, it is not safe. That is the whole purpose and crux of, holding these programs, that we should we should be aware that this is a hospitalization one category, definitely. Other thing is, she needs to be protected from that environment which has led her onto this. There may be some people whom she trusts onto, so we can sit and confide things with them, and then maybe try to help her.
And Dr. Monica, there's one question that as we are working in the small hospital, so how to manage this? Because in multi-speciality, you can manage it easily. That everyone is
course.
There. But if
you are working in
two doctor, then how to
manage
it?
Dr. Yasmin, I completely agree that that kind of multidisciplinary approach is most of the times not available in small clinics. But that actually doesn't mean that we will just let the patient go away just like that without offering any help. Maybe in our consulting network or whatever, we have some help available, like if she has some mental issues, we can always guide and usher her to people around. And actually the female herself should be made aware that she is going through some problems. If she has been courageous enough to report it to you, then in your capacity, whatever possible is there. Else, of course, in all your areas, whoever are small practitioners, they have tertiary level hospitals available. So at least as a responsible physician, you can guide the patient to those hospitals. You can always document it. Of course, eventually to follow or not is on the, the onus is on the patient herself. But help should be extended at every, and you can help only when you know things. So
Yes.
that is the crux. So I would practically urge all the participants who are attending this program, so that they should make themselves completely aware of all these things, and of course, at whichever level they can help our women around, that will be really great. No matter you are working in a small setup, a single room clinic, or maybe a multidisciplinary clinic, or maybe a tertiary level hospital, whichever way you can reach out to the women, that is our prerogative. Thank you.
Very true, Dr. Monica, because see, whichever place we are, we definitely have, most of us will have some psychiatrist to help us, or no, if nothing, at least we can give them is a women helpline, where they can access the women helpline, which is a national helpline, where they can go and report. And if not, then there are cells now in most of the police stations. At least in Maharashtra, we do have sensitized police officials, not everywhere. I'm sorry to say it's not so universal, but yes, I mean, we can always help them as far as this is concerned, and get them at least some temporary protection, because she has come out from a violent state. She has reported. Now after that, if she has to go back there, it will be
and the approach to such patients has very nicely been already taken, and there's another presentation in which we can give them a lot of information with the numbers and the institutes
Support
where all she
centers.
can approach. Support centers.
Yes,
So government has done immensely for these, I must say, the females. I should not call them patients, but it's our duty now onwards to actually usher them to the right places. So maybe we can now invite the next speaker.
Thank you so much.
Yeah.
Okay.
Please make me the co-host so I can share this presentation.
I made you co-host.
Okay. I don't know what this is. Just a minute, sorry. One minute. As Jayashree Madam told, that we should talk about our safety also. So that is our duty, that first make ourselves safe. So I'm going to talk about this challenging situation in war and the self-care. And I'm really thankful to Mr. Ajay Bhagwat sir and Dr. Kiran Mai. They have made this presentation very nice, and thankful to the Dr. Shanta Kumari, that is our Foxy president, that she is running this program. And this is I think everybody needed this. So challenging issue when dealing with the survivor who may be feeling hopelessness, having a suicidal thought, or in harm way. What would you do? So you are a gynecologist, one of your patients in your clinic tell you she is being threatened by her mother-in-law, who is constantly pressurizing that she must divorce her husband because she is unable to have children, and she feels hopeless and want to give up. So that is a common, and also for the female child in our area, mostly in, I'd say, that is in Rajasthan, it's common. So you would do nothing or you would do something. So put your answer in the chat box. It's not doing slideshow.
I'm sorry to interrupt you, madam. It is not full screen, ma'am.
Yeah, that's why I'm sharing. That is correct. Now it's full screen.
Yes, ma'am.
Yeah. So just write in the chat box, are you agree or not? So few ideas are there. Be able to recognize sign of depression and suicidal risk. Do not afraid to ask the patient, are you having thought of suicide? If the answer is yes, take it seriously, as we discussed already. Do not leave the suicidal survivor alone if there is an immediate danger. As we discussed that we will refer to them to some agencies or we will admit them in the hospital. Do not always consult a supervisor about how to refer or manage a suicidal survivor, never make a decision on your own. So we sole are not responsible, as we are discussing from the first lecture only. This is for your own safety and well-being. Provide a referral to the GBV expert, that is a gender-based violence expert agency, and OSC for additional help if possible. So OB-GYN should not ask survivor about the suicidal thought or attempts. It could encourage suicidal attempt. What do we think about it? It's true or false? So please put the answer in the chat box. Yeah, it's false. So this is the false. Asking about the suicidal attempt or thought does not increase the suicidal attempt. On the contrary, talking about the suicide often reduces the woman's anxiety about the suicidal thought, because if she will talk to someone, her stress will reduce. So help her to feel understood that what she is planning. If the survivor tell you that their abuser have threatened to harm them, what should you do? So put your answer in the chat box. That we are discussing from initially, what you will do for suicidal. So few ideas are there. That ask concrete question about the safety risk, but only when there is a privacy. So always remember that we have to maintain the confidentiality and we will make the patient dignity and the privacy. So we will take care of this, that we will ask the question in private. So ask if survivor have a safety plan in place in case she need to flee, because we need to have our identification, that certificate like Aadhaar card and all. So she should keep something in a place. So whenever she feels that she is unsafe, she can flee from that. So discuss potential strategy for being able to leave her situation safely. So just keep some money and some things which are essential for her on a one place. So provide a referral to the GBV expert, agency, OSC, one-step crisis center for additional help if possible. So we need to take the phone number and this with us only whenever we feel we can refer in our city. One of the most helpful technique for helping a survivor to get out of an overly emotional state, to ask them close-ended questions that require them to think. Always remember, open-ended question, that means she is going to tell you a story. And close-ended question, that is only having the 1 or 2 word answer or yes and no answer. So shift them from emotional state to the cognitive state, because you are diverting her. Should require a short answer. Do not return to the open-ended question unless the survivor feels comfortable and has to some degree of emotional control. So what are some example of the close-ended question that you might go to in a situation like this? Idea in the chat. Example, how many kids do you have? She will say that 2 or 3. Are they in school right now? Yes and no. And what ages are they? So this is only the close question we are going to ask. Challenging issue. When dealing with the survivor who may be mentally ill. So state clearly who you are and your role. So always introduce yourself and tell the role you are going to play for her. So be empathetic, not threatening, and sincere in your intention to help. So remember, be empathetic. It is not sympathetic. We are not going to give the sympathy to the woman. Give honest and factual answer whenever necessary. If you do not know, say no. Okay, so remember, if you don't know anything, just say no, I don't know about it. Do not belittle concern which the survivor raises. Do not give advice as to handling of their psychological problem. Attempt to be supportive and comment and gesture. So you have to show the body language also. That is already given in by the Dr. Monica in the first lecture. Do not assume mentally ill patients should know better, or on the other hand, that they need to be told what to do. So be careful about making any assumption. So don't be judgmental. That is Madam told already. Know how to activate emergency mental health backup. So we need this, that we have to start the emergency backup for her. Additional challenging issue, that is a mediation. That is very important, that we are going to mediate or not. So what do you think? Can we be part of mediation process? Any answer? So remember, mediation is not recommended as a response to the gender-based violence. So we are not a mediator, we are referral only. We are going to refer the patient. So remember, healthcare workers are the part of the survivor-centered referral mechanism. The mediation process itself maintain and contribute to the abuser's ongoing power and control over a survivor. The process of mediation presumes that both parties can speak freely and confidently and safely. That is not the case. So mediation rarely results in the end to the abuser's violence and can actually lead to increase in violence, as Jayashree Madam told us. So that is the one fact that even it is rarely, but it can happen. So it's unlikely that the survivor's right will be respected. So if survivors say, I don't want to inform, then we cannot force her to inform. Core safety precautions when dealing with the challenging issue or cases. Multiple people can handle difficulty better and more effectively than one person. So that's why we need the MDT. A service provider should never feel like he or she must work alone with the survivor. So we are not the sole responsible. It should be team. A service provider should not work with the both perpetrator and survivor, neither separately nor in the same interview. So remember this, we are only on the one side. Keep the office door open of leaving the office or home if feeling unsafe. Establish a code, that is a code word with co-worker to identify unsafe situation. I think we need, this is the need of time that we have a code word for this. As we are doing the for emergency like blue code, red code, same we have to for this also. Establish a relationship with the local police or security. Use buddy system at work and to and from work, and if doing home visits. So we have SOS group in our Jaipur, so I think everybody have. Use supervision to the address security concern. A group of people can address security more effectively than the individual. Self-care for the provider. It is critical for you. So do you know what is a vicarious trauma? So put your comment in the chat box, yes and no. That is for ourselves. As a service provider, you should be aware of it for the self-care. Now, defining the vicarious trauma, a change in the service provider's inner experience as a result of emotional engagement with the survivor of trauma and hearing their stories. That we connect sometime in movies. If the movie is very like if the heroine is weeping, sometimes the people are also. So that we are engaging. So we are engaging with our patient also. So change that occur in the service provider's physical, emotional, and behavioral state as a result of the constant exposure to traumatic stories or event. So causes of vicarious trauma. Constant exposure to stories of trauma. Desire to help change the survivor situation. Feeling powerless when a service provider does not see positive change in the survivor situation. That's happened so many times. Overly identifying with survivor. Thinking that the service provider have the power to change the survivor situation. So preventing and managing vicarious trauma, there's a ABC is there. A is awareness. So we should aware of them. Being attuned to one's need. Limit emotions and resources, practice self-acceptance. Balance, maintaining balance among the activities, especially work, play, and rest. Connection, maintaining supportive relationship. Communication is a part of connection and break the silence of the unacknowledged pain. These connections help prevent the isolation, increase validation, and hope. So self-care for the healthcare provider. Creating boundary in the workplace. So we have to create the boundary that after that we are not going into this. So establishing support within the work system, seeking assistance from the outside agencies, and creating our own self-care plan and follow them too. Now quiz, there's empathy and sympathy that is already we have done in one of the lecture, Dr. Gori have taken. So pick which statement describes sympathy and which statement describes empathy, because we are going to give the patient empathy more than the sympathy. So statement 1, a personal emotional identification with the survivor's experience and implies that the service provider feels sorry for the survivor It is an emotional state that leaves the service provider vulnerable to over-involvement and can take power away from the survivor. Statement 2, an intellectual, personal understanding and realistic professional distance. It involves compassion and objectivity and leave room for the empowerment of the survivor. Now write down in the chat box, what do you think about the statement 1 and 2? So that is a empathy versus sympathy. Sympathy is the personal. So first one is the sympathy. So sympathy is the personal emotional identification with the survivor experience and implies that service provider feels sorry for the survivor. It is an emotional state that leaves the service provider vulnerable to over-involvement and can take power away from the survivor. So it is identified with survivor experience, though your own shoes. Empathy implies the intellectual person understanding realistic professional distance. It involves compassion objectively and leave room for the empowerment of the survivor. So it's attempt to put oneself to the survivor's shoes. So we need to empower the woman. So how do you take care of yourself? Put in the chat box. So that is some relaxation and self-care technique you can use. Somebody have asked. Okay. So that is again, I'm going to remind you to that is finishing the lecture, that certificate will be awarded to the participant on course attendance and submission of registration that you have done already. Pre-test is done and post-test and feedback is required to complete this and you will get the certificate. So any question? Okay, I think I will hand over to the Prema. Dr. Prema, that's your lecture is next.
Yes, ma'am. Thank you, ma'am. Thank you for your discussion.
Yeah, thank you.
The next is the most awaited one, that is the support systems and resources for survivors. So coming to the overview of the section, so it includes what are the protective laws and acts, what are the helplines, what is OSCC, that is One-Stop Crisis Center, how can we link up and help in rehabilitation of the survivors. So coming to the Protection of Women from Domestic Violence Act, started in 2005. This may be called as Protection of Women from Domestic Violence Act. It exists to the whole of India except state of Jammu and Kashmir. So initially in 1983, the IPC 490A was there. But now this Domestic Violence Act 2005 was there. Why? Why it was started? So the importance of this Domestic Violence Act 2005 is, in the previous one, there is no emergency relief available to the victim. The remedies available were linked to matrimonial proceedings and the court proceedings were always protracted, during which period the victim was invariably at the mercy of the abuser. Relationships outside marriage were not recognized. So that's why this Domestic Act 2005 came. It is a civilian law. In 498, a husband is liable for punishment, but wife does not get any financial relief. In Domestic Violence Act 2005, the wife or female partner gets relief, but there is no punishment or arrest unless the husband violates a court order. Another difference is that 498A can be booked against husband or his relatives, that is family members. But Domestic Violence Act can be booked only against the male members of the family. So I like to remind you that Domestic Violence Act 2005 can be booked only against male members of the family. It provides financial relief and there is no punishment unless the law is violated.
Hello.
So who can be complained? Shall I proceed, ma'am?
Yes, madam.
Yes, thank you. So So who can be complained? It could be a wife or a woman based on consanguinity, marriage, adoption, or cohabitation against a male abuser in a shared household. A woman who is in a relationship similar to a marriage with a man, technically a transgender male to female, could bring an action against a transgender female to male. A woman in a live-in relationship with an unmarried man, but not a man who is married if she knew or ought to have known that he was married. Anyone can file a petition with the survivor's consent. So the complaint can be given to protection officer, service providing centers, medical officer in charge, police station, or a magistrate. Where you can complain? Jurisdiction under the Prevention of Domestic Violence Act. Complaint includes where the wife permanently or temporarily resides or carries on the business or employed, or where a husband permanently or temporarily resides or carries on the business or employed, or where the cause of action or crime has arisen. The wife can choose any of these three options. What are the types of orders? It could be protection orders, stop violence orders, emergency relief, custody order, compensation order, violation of above order, an offense, and magistrate may charge an offense. Under section 31, non-compliance of a protection order by magistrate can lead to issuance of non-bailable warrant. The act requires that all the proceedings brought under the act may be disposed of within 60 days of the first hearing, which must occur within 3 days following filing the application. The service support include filing a detailed investigation report, providing shelter, giving shelter for temporary shelter of about 5 days, facilitating free legal services, providing counseling services as required. So coming to the legal remedies available in India. So Article 14 deals on equality. National Commission of Women Act 1992 was there. Then Dowry Prohibition Act, then IPC 498A, which is the most widely used provision against domestic violence. And finally is the 2005 Protection of Women from Domestic Violence Act. So the concept of one-stop crisis center was established. It's mainly to provide immediate medical, legal, and psychological needs for women who are the survivors of abuse, which could be a physical or mental abuse, with an assurance that the consent and confidentiality will be respected and protected. Today, almost 234 one-stop crisis centers, that is Shaki centers, were there all over India. However, the first one was started in Madhya Pradesh, Gauravi, in June 2014, with staffs of 10 focus on victims' need without compartmentalizing the services, by a joint initiative of Department of Public Health and Family Welfare and Government of Madhya Pradesh. Then, the Bharosa Trust She Team's office was started in Hyderabad. It provides all services in one go, such as police services, counselors, psychologists, legal advisors, medical help to the woman affected by violence. The helpline is 100 and it will be directed to Bharosa if there is violence. A woman can walk in with assurance that her consent and confidentiality will be protected and respected. And here we can see the Bharosa team started by under the guidance of our president, Dr. Shanta Kumari ma'am. So this one-stop crisis center is mainly intended to provide support to women affected by violence. It could be from the family or community or workplace. And the type of abuse can be a physical, sexual, emotional, psychological, or economic, irrespective of the age, class, sex, education, race, etc. So the main objective is to provide integrated support and assistance to women affected by violence and to facilitate either immediate, emergency, or non-emergency access or services, which includes medical services, medical treatment, forensic DNA test, police assistance, legal support, social welfare services, psychological counseling, safe custody or shelter home, rehabilitation, and social reintegration services. So who to contact? So I request you all to take the screenshot of this. So these are the major helplines across India. For the women's domestic abuse, the helpline is 181. For the All India Women Helpline, the number is 1091. For POXCO, it is 1081. For helpline for women in distress, it is 1091. And these are the helplines, the Delhi Commission for Women. Please take a screenshot. And these are the helplines, one-stop crisis centers available in Andhra Pradesh, Arunachal Pradesh, Andaman Nicobar, and Bihar. Please take a screenshot of these helpline numbers so that you can share in your groups or societies so that you can help somebody else who is in need of it. And these are the helpline numbers for the union territories such as Chhattisgarh, Dayu Daman, Delhi, Goa. And these are the helpline numbers for the Gujarat, Himachal Pradesh, Jharkhand, Jammu and Kashmir, Karnataka, Kerala. And these are for Maharashtra, Mumbai, Manipur, Meghalaya, Mizoram, Nagaland, Northeast. So you can take the screenshot of these and you can share in your local societies or your friends group so that it can save somebody in need. And these are the helplines for Orissa, Puducherry, Punjab, Chandigarh, Haryana, Rajasthan. And these are the helplines for Tamil Nadu, Telangana, Tripura, Uttarakhand, Uttar Pradesh. This is for West Bengal. So I hope you get the clarity of what are the support services available and what are the helplines available. So I like to remind you all, please fill the post-test and feedback form to get your certificates. Thank you all. Are there any doubts? If not, shall we move on to the next session?
Thank you, Dr. Prerna. I think so. If we don't have any problems, we can move on to the next session.
Sure, ma'am. Thank you, ma'am.
Okay, thank you. Can I please share my screen now?
Yes, ma'am.
Okay, thank you. So is it, please, my screen is visible and I'm audible?
Yes, ma'am. You're
Okay.
audible and visible.
Thank you so much.
So
So
make it full screen, ma'am.
it is full screen? It's not full screen?
No, ma'am.
Okay, just a minute. Let me do it. Okay, is it full screen now? Can somebody help me?
No, it's not full screen.
No, it's not full screen.
Okay, ma'am, I'll just stop share and again share with you.
Ma'am, after clicking the share screen button, yes, it is fine.
Yeah, now it is okay.
Okay, thank you so much. Thank you. I'm so sorry for this technical glitch. So we have all heard about domestic violence, the various aspects and how do you approach. So and now a little bit about how do we actually go about in a patient who is having sexual violence against any survivor of a sexual violence. So I'm thankful to Jyoti ma'am and of course Kiranmay ma'am and Ajay sir for taking all this study material available to us. And of course Shanta Kumari ma'am, because this is her her child in which we are all involved so that the incidence of sexual violence or any form of domestic violence against women is taken care of. Am I this moving? Hello, can somebody please tell me, is my screen moving?
I've changed the slide. We can't see, it's not moving. We can see the full screen now.
Okay.
Can you move one slide and show us? No, you're not screen shares.
Okay, just a minute. I think so. It just lost it again. Is it visible, please? Is it visible?
Once again, it's not a full screen.
Not full screen. You have to just double click there, ma'am, then it will become full screen.
But actually, it is showing full screen to me on my laptop.
Ma'am, after clicking the share screen button, just you click share. There is one option is there. There are so many windows will be open. After clicking the share screen button, just you click the share. Yes.
Yeah, now it is okay.
Okay. Thank you so much, ma'am. Thank you. I'm so sorry. So if you look at the definition of sexual violence, we have to understand that sexual violence refers to any sexual act or any attempt to obtain a sexual act. It is usually unwanted and it is again directed against a personal sexuality using force by anyone. It is regardless of the relationship to the victim and in any setting, including at home or at work. So this is what we have to understand. These are the various components which will define what a sexual violence patient is like. I'm so sorry, I am not able to move my slide.
No problem. You right click on your slide and you will see the drop in. You click next.
Ma'am, has it moved?
Yes, it has.
Okay, thank you so much, ma'am. So I think so everybody has heard about rape, which is the most common form of sexual violence we all know about. But if we look at the WHO definition of sexual violence, we have to understand that rape is just a very small part of it. And actually, sexual violence is defined as any physically forced or otherwise coerced penetration of vulva or anus using a penis or any other body part or any object. So this entire spectrum would be what would involve any patient, any survivor of sexual violence. So there are some facts about sexual violence that we all have to know, is that we all must be knowing somebody who has had sexual violence or who has experienced sexual violence in her lifetime. And the worst part is that these victims are usually, their assaulter is known to their victims. What we have to realize that it is never the fault of the victim to be a patient of sexual assault. We have to understand that rape is the least reported and convicted violent crime in the world, and sexual violence is preventable and help is always available nearby. If you look at the various forms and contexts of sexual violence, it can range from rape within a marriage or a dating relationship, rape by strangers, or systematic rape during any armed conflict like wars. It could be an unwanted sexual advances or sexual harassment, including demand of sex in return of favors. It could be because of any sexual abuse of a mentally or a physically disabled person, or even sexual abuse of children. The other form of sexual violence could be in the form of forced marriage or cohabitation, like child marriages, any denial in the use of contraceptive, or any other measure which can protect the survivor of sexually transmitted diseases, forced abortions, or violence acts against sexual integrity of females, including female genital mutilation or obligatory inspection for virginity. It could also range from forced prostitution and trafficking of women for the purpose of sexual exploitation. So sometimes these sexual violence could be like customs of child marriage, which is very prevalent in India. We have to understand that if we legalize child marriage, it is a form of sexual violence, especially against young children and girls in particular, because these children are unable to withhold or give consent for their marriages, as well as majority of these children have little or no knowledge about sex once they enter into this marriage. So once we have recognized what is actually sexual violence, we have to understand what are the consequences. It could range from pregnancy to gynecological complications, presence of sexually transmitted disease, and of course, mental health issues, suicidal behavior, and social ostracization. Sometimes these sexual violence may result in fatal outcomes like suicide, homicide, or AIDS-related illnesses, whereas the non-fatal outcomes could be physical or psychological. The physical consequences could range from unwanted pregnancy, infertility, sexual dysfunction, chronic pelvic pain, various types of sexually transmitted infections, obesity, anorexia, urinary tract infections or gastrointestinal disorders, any gynecological and pregnancy complication, various frequent types of migraines or headaches, fatigue and nausea. The psychological consequences could range from post-traumatic stress disorder or rape trauma syndrome, social phobias, shock, increased substance use or abuse, denial, fear, confusion, anxiety, guilt, depression, alienation, and eating disorders. So this is once we have understood what are the various consequences and what exactly is sexual violence, we have to understand that an approach to this survivor of patient sexual assault is a very delicate issue, and because this sexual assault is one of the most invasive and intimate forms of violence. So what is known as a trauma-informed care approach has to be taken. This involves understanding of the neurological, biological, and the psychological and social effects of trauma and violence of the individual. Once we have realized that this patient is reporting a sexual assault, we always have to triage the patient as a medical emergency. So what is immediately required is medical and psychiatric evaluation and stabilization of the patient, activation of the community advocacy to the bedside, mandate reporting to the state authorities, offering and conducting, if it is required by the survivor, the sexual assault forensic exam that is known as SAFE. We have to collaborate with the law enforcement if required by the survivor. Also take care of the prophylactic medication to prevent various types of sexually transmitted infections and diseases. The pregnancy risk evaluation has to be taken care of and safe precautionary measures to be delivered. And those providing medical and forensic care must always be prepared to provide testimony as either a fact or an expert witness in later times. So once we talked about trauma care, it involves safety, trustworthiness, choice, collaboration, and empowerment. These are 5 components of these once we are dealing with any patient of sexual assault. So coming to the safety point, it would always remember that whenever we are entering the patient's room, we always have to knock and ask permission. We always have to meet the parents before we try to examine the patient or disrobe her. Always ask the patient before we ask her to disrobe. We have to clearly define where are the washrooms in case she wants to use them. We have to take time to familiarize the patient with the physical environment of the room, as well as we have to show her respect and share control with her. We have to be always warm and compassionate in building rapport with the victim. Coming to the trustworthiness part, we have to explain each and every procedure in terms to the victim so that she can understand what to expect and how long it will take. We have to ask the patient if she wants anything or any comfort is required for her in any means that has to be delivered to her. The choice has to be offered to the victim. We have to always ask before touching her. We have to ask before we want to invite any additional staff. Before we close the door, we have to always ask the victim and respect her choice. We can ask her to sit wherever she feels comfortable, explain, rationale for each procedure, what it entails, and whatever modifications required, we have to do to reduce the chances of re-traumatization. We have to obtain consent for each part of examination that we are going to perform. We have to collaborate and ask her what is most important for her and what is worrying her most. We have to take care of that thing first, share the information, and always encourage the person to discuss about various modalities of the treatment offered. Coming to empowerment, we have to make sure that we have to make her understand, yes, what she has to do next. We do not ask her, what is wrong with you? Never say why, because this implies fault on the part of the victim. We have to take time and always show that we are genuinely interested and in hearing her complaint, never in a hurry, and always respect her preferences, which may be related to any difficulty of a procedure. We always have to ask her and take her permission before we start the procedure and make it easier for her. We have to make her relax and take her whatever position is comfortable to her. Always make sure that we pay attention to her body language, because many survivors have been conditioned to be passive and defer authority, so they may not disclose distress during any procedure. So coming to, this is how we deal with any patient of sexual assault. And finally, once we are taking the history, we have to take care of any medical history, any recent consensual sexual activity, any assault-related medical history, any sexual assault details, nature of the physical assault, post-assault activities, and of course, the suspect information. This is how we approach any patient of sexual assault. We request everybody, we know that once you have registered for this webinar, you all have filled the registration form, and with that, the pre-test also. At the end of the session, we would request every participant to please fill the post-test and the feedback, so that the further sessions, we may improve in the further sessions. And I'm open to any questions if anybody has any doubts. Otherwise, we'll move on to the last session and request Monica ma'am. Hello.
Yes, I'm here.
Oh,
I'll just
thank
share
you,
my
ma'am.
screen.
Thank you, Monica ma'am.
Thank you, Dr. Meeta. So is my screen visible?
Yes, ma'am.
Okay, then.
Not a full
So,
screen, yeah.
Yeah, I'll do that.
Okay.
So, having gone through, this comprehensive module of gender-based violence, I now would like to take you through this last segment, which is examination of a survivor and collection of evidence. And this is sexual assault survivor. And mind you, sexual assault being the most heinous of the gender-based violence act, which a person can go through. So we have to be really very sensitive, and in fact at the same time comprehensive in the evidence collection, and in terms of whatever medical legal help we can extend to the survivor. So during this session, you must understand that what is actually the role of gynecologist in such issues, which is using important evidence of the crime, helping judges to understand physical and mental condition of the survivor, using reports to corroborate the survivor's story and enhance credibility, offer primary level counseling treatment and referral for the physical and psychological sequel. Now, medical examination would actually include a comprehensive recording history. This is very, very important for anybody to move further in such cases, and finding evidence and finding the scenario behind how the act occurred. And if the patient is able to tell verbatim, everything should be noted down actually verbatim. And after that, patient has to, even prior to that, the patient should ideally be undergoing a fully informed consent. She should know why is she being medically examined, what are going to be the consequences, and how this all process will eventually help her in achieving justice. After that comes the injury documentation. If you find any injury marks or any kind of physical injuries all over her body while doing examination, of course, with her consent, and eventually the evidence collection, nature of sexual violence, time elapsed between the incident and examination, whether survivor has bathed or washed, everything needs to be documented. At the same time, I would request all the participants to please keep putting the queries, because this is one very sensitive topic, and we have seen even as as the nodal officer of almost the biggest tertiary level hospital, that till date, doing after so many trainings to the postgraduates, the time and again they come up with some or the other query. So I'm sure if whatever queries we can cater, we'll be. You are most welcome for that. All of this process involves actually major 25 things to do. I mean, they have been numbered as 25 so that we are not losing out on anything which is required to be done. Now, 1 to 11 will actually include general instructions. This is the general demography of the patient, which I'll take you through after this slide. Then comes informed consent. It is must to be taken before proceeding on to any kind of medical legal examination. Marks of identification, relevant medical and surgical history, any history of sexual violence, type of physical violence, emotional abuse, etc. Of course, a comprehensive general physical examination goes without saying. Then comes the actual injury marks, which needs to be documented. Minor injury, major, grievous hurt, whichever way we all know injury documentations. External genitalia to be specifically commented upon if there is any such related history. Systemic examination, and 2021 will be the evidence and sample collection, which I'll tell you in detail. Provisional medical opinion. You must not leave the medical legal form without your provisional medical opinion. And that doesn't mean that you are, pinning the survivor with the diagnosis of rape. What you must understand is that rape is actually a legal term, and what you are doing is just a medical legal examination of sexual assault. Now, pinning the term rape is actually court's purview. That depends on whatever evidence they eventually get and collect. So after that comes the treatment prescribed, date and time of completion of examination, and of course, final opinion is finally formed after all the evidences are collected and the results are obtained. Now, this is, as you can see on your screen, are the general instructions, which includes usually the demography, name, daughter of, OPD number, inpatient number, and of course, it includes the MLC number as well, which comes down the line at number 9, but this is a must thing. Address, age as reported, the date of birth, sex, date and time of arrival in hospital, who has brought the patient, his name and signature. Mostly 99% of the times they are brought by some or the other constable to you. So even the belt number and the name of that constable should be mentioned. Otherwise, if a relative or a best of kin brings the patient, that needs to be mentioned. Whether she was brought conscious or coherent, oriented in time, place, and person or not, everything needs to be documented. Any physical, intellectual, or psychosocial disability which you are already aware of, or she is able to tell you that this was the known case, then that needs to be mentioned. And if in cases of survivors speaking a different language than yours, then in that case, even interpreters and special educators can be sought. This is the provision under law. They can be called for. Okay, then comes the informed consent and marks of identification, which is very, very important in such cases. And this is the format on your screen, which is generally followed in the medical legal forms, that I, daughter of so-and-so, wife of so-and-so, or son of so-and-so, depending upon who the survivor is. Medical examination, I consent, yes or no. Medical legal examination, I consent, yes or no. We should understand that there is a difference between just giving history and telling you about the incident and undergoing medical legal examination. A person can be willing to talk, but she may not be willing for particular medical legal examination. So a separate consent is required. And those who are actually not willing for medical legal examination, actually you cannot force that. But yes, you should make them realize the implications, medical legal implications of not undergoing such an examination at that particular time when they are reporting to you. At the later date, if they plan to and come to you and say, now we want the examination done, then most of the time has elapsed, the valuable time in which the evidence can be properly collected. Okay, then sample collection for clinical and forensic examination, as I said, has to be separately consented, yes or no. I understand that as per law, hospital is required to inform police, and this has been explained to me. Mind you, for all those people who are listening to this talk, if they are private practitioners, even they are bound under law to report such an event to the police. They cannot be saying that go to the next tertiary level hospital and get yourself examined there. Do whatever is possible in your purview, and if the survivor happens to report to you, and in case you are incapable of specialized medical legal sampling, then just inform police, make an MLC, and then with due reasons and concerns, you can let the survivor, or you can of course inform the constable to head to the nearest tertiary level hospital. Okay, and then of course the survivor needs to sign that I have understood the purpose, the procedure of examination, including the risks and benefit explained to me by the examining doctor. And in fact, an informed refusal is also required to be documented. You must know this. Even if she's refusing that I'll not get examined, I'll not get medical legal, I'll not get examined, I'll not let you collect my samples. So even that has to be very nicely documented and signed by the survivor and the witness. Any scar or mole, this we all know, marks of identification need to be documented on any MLC. Then relevant medical or surgical history, depending upon whichever way they have been documented, in the most important being last menstrual period. And this is important because you never know, in case of unprotected sexual assault, she will have to be followed up after a certain period of time to make sure that she has regained her periods, or this results into some kind of a pregnancy. History of sexual violence, as I said, needs to be documented verbatim. It includes everything: time of incident, location, estimated duration of assault, where was it a single or a multiple episode, number of assailants, whatever she can recollect and tell you, even the names, sex of assailants, approximate age, relationship to the survivor, description of incident, narrator of the incident. If it's not survivor herself, then any other informant who's accompanying her, that needs to be very specifically mentioned with the relationship to the survivor. And of course, if the form is insufficient, you feel that usually there is a big box given in the medical legal form to be filled. If not, then you can use an extra page at your liberty and attach it. Then type of physical violence, used, if any. Generally, they use hand tie, or they hold back the fist, blunt object, sharp object, injuries might be seen. Whatever patient is reporting, please mention it. She was burnt with something, kicked, pulled hair, or banging head, dragging, biting, pinching, violent shaking, anything that needs to be mentioned, because eventually the injury marks, and when the judges do the comprehensive analysis and they give their judgment, everything is based on evidence only. So if you lose out on mentioning some of the other history which he had mentioned, maybe the survivor does not get the benefit of all of your help. Then emotional abuse or violence, if any, use of restraints, use of threatened, use of threatening or use of weapons or objects, if any, verbal threats, example that, she may be given threats of killing or hurting the survivor, or any other person survivor is interested in, the photographs, blackmailing, luring, in case of, especially important in case of young girls, sweets, chocolates, drinks, alcohol, drug, money, job, anything needs to be mentioned. Any history of substance abuse, or alcohol or drug intoxication, whether sleeping or unconscious at the time of incident. If the survivor has left any marks of injury or an assailant's details, because at times, when the survivor is strong enough or physically fit enough to be, opposing the act, then she might use her nails or any other injury marks can be left on the assailant. So all those details can be matched with the medical legal examination of the perpetrator also. Then this is the details regarding sexual violence, any which way we have discussed all, but this is in particular that whether penetration occurred, by penis, fingers, or object, or on other body parts. You have to write yes, no, or don't know. It could be oral involvement, see mouth, hair. So everything is documented. There can be different forms in which it is documented in the medical legal form, but all such things are there, and ideally no column should be left blank. They should be thoroughly read and filled. That doesn't mean that everything has to be, whatever is the relevant history which the survivor is giving needs to be properly mentioned. Details regarding the sexual violence, as I said, again, could be oral sex, forced masturbation of assailant or self, exhibitionism, did ejaculation occur outside the body, or if is vagina, anus, mouth. All these are important because according to the history only, you will be eventually collecting the samples. It's not that each and every place oblique mention needs to be sampled. The sampling also needs to be history directed. If yes, where on body, or whether the condom was used. If yes, the status of condom, whether it was found with the body or at the site of crime. Lubricant used. If yes, describe the kind of lubricant. If object was used, describe the object. Okay. Then the post-incident details, whether she has changed clothes or undergarments, whether she's washed them by the time she came to you, because that you will lose on evidence if such thing happens. And whether she has douched the local area or passed urine and stools, rinsing of mouth, brushing, vomiting, everything. This is a very, very comprehensive form. Ideally, it should be available, especially in government institutes. So definitely it is available these days. It's been so many awareness drives are going on all around, and Ministry of Health and Family Welfare is doing every bit possible to spread the guidelines and the evidence collection kit. If not, then we should make ourselves aware, and of course make sure that even in small setups we have at least available equipments to sample the patient. Then general physical examination, like any other examination, includes all these comprehensive things. Examination of injuries is very important to be documented, and everything possible with that injury mark in area needs to be reported. And also those body diagrams which are there in the MLC paper, which I'm sure all of you must have seen, they need to be properly attended and attempted. Bruises, nail abrasion, teeth bites, cut, lacerations, fractures, tenderness, boils, burns, all need to be mentioned. Where exactly on the body part, scalp, face, neck, shoulders, breast, wrists, forearms, medial aspect of thigh, upper arms, buttocks. How means what actually is the shape and size, color, swelling, any signs of healing. This will tell you, how late has she reported to you, whether it was a simple or grievous hurt, the dimensions of the injury. External genitalia, very important. Labia minora, majora, urethral meatus, vestibule, whatever you are seeing, please comment on it. That doesn't mean that you need to actually put in, as they have said, that there is no law. There's no law or any particular guideline which says that each and every patient need to be undergoing a PSPV. Of course, if indicated, only then do it. Which in local terms, there's a lot of hue and cry about that 2-finger test, which is nothing but the pervaginum examination. Should only be done when it is indicated, and it should not be done unless required for detection of injuries or for medical treatment. So write if PS findings are there and if it was performed. Don't mention if it was not. And of course, we have to record the reason that is nothing but the relevant and pertinent history why that was being done. And any other important findings in oral cavity, bleeding, discharge, tear, edema, tenderness, all need to be reported. Systemic examination, yes, like any other thing, any important finding in other systems, CNS, CVS, respiratory, abdomen need to be mentioned. And now comes very important evidence collection. And this is actually to confirm the allegation, to establish the link between victim and the scene, and to establish the link between victim and assailant. Every contact leaves a trace. This is actually the theory behind sample collection. So it is actually, we have to make sure that we are maintaining the chain of evidence. We are identifying the specimen and labeling the specimen properly, the label, assigning the label, and report the disposal of the specimen. Everything needs to be documented, because at the end of the day, this is a medical legal procedure, and any step of this you cannot fall short of. Hospital laboratory and clinical laboratory samples which are sent usually to your own local health setup are the samples for HIV, VDRL, HBS, and HCV. These don't go to the forensic science laboratory. You can do the point of care urine test for pregnancy, of course, ultrasound and for pregnancy, and judging the internal injury and X-rays can be done at your local setup. Central State Forensic Laboratory is the one which is central to a particular state, or maybe if not available in your particular area, they are sent to the nearest available major laboratories. Like in Delhi, I can tell you, we have this huge National Forensic Science Institute, LNJN, which is situated in Rohini. So usually all the samples collected from Delhi NCR go there. Debris collection, paper, clothing evidence, wherever available, these all are to be collected and sent to the forensic science laboratory after proper air drying. Mind you, it has to be air dried and properly sealed and signed. And usually for government setups, they need to be stamped as well. Now, sample collection is a very, very comprehensive process. And we should not be afraid of this, because the kits which are available these days for sample collection are very well self-directing. You would find the various envelopes. There are 13 to 14 envelopes inside that safe kit, and they are self-explanatory. Every envelope would mention a particular thing, like swab from body, scalp hair, head hair combing, nail scrapings, and you would actually find the comb also in that. Say for head hair combing, you will find a comb in that envelope. Nail scrapings, you would find either a spatula, small one, or nail cuttings. We will find even a nail cutter inside the safe kit. So you don't have to run from pillar to post to collect the things required to do all these sampling. You can simply order for these safe kits for your institute or your setups and go through all this procedure very nicely. If not collected, why you are not collecting the sample also needs to be mentioned. If the stain from the stain on the survivor body has dried out, then you can use a bit of saline, which is also available most of the times in the safe kit. Just wet that area and collect the swab. Genital and anal evidence, again, like matted pubic hair combing, cutting of pubic hair, vulval swabs, vaginal swabs, anal swabs, vaginal smear, urethral swab, all of them are there. These all mentioned and labeled envelopes are there within the safe kit, which you can make use of. Then comes sample to be preserved as directed till handed over to police, and you must mention the safe custody to whom you have handed over the specimen, which is very important, till the time it reaches the forensic science laboratory. And of course, last comes the provisional medical opinion, where you are supposed to tell that my findings are as follows. I have collected these many samples, and these are my clinical findings. And of course, this is the additional, any other additional observation which you have made needs to be mentioned. Then comes treatment. Of course, she has come to a medical facility. Some or the other kind of pertinent treatment should be given, and this has been very nicely mentioned in the the guidelines of sexual assault survivors provided by the ministry also. So you are supposed to give STI prevention treatment, emergency contraception, wound treatment, tetanus prophylaxis like any other wound, hepatitis B vaccination, post-exposure prophylaxis for HIV, counseling needs to be done. Ideally, in one-stop centers like ours, where we have 24/7 counseling services available. Usually, the women councils and women commissions around, they provide you with the counselors for your this thing. And in fact, there's a central helpline number also available most of the centers where you can seek help for counseling, especially in POXO cases, which is for the survivors less than 18 years of age. Okay, and then of course, any other treatment for the pertinent ailment which you happen to find while examination. Then it is not complete, the documentation, without of course the date and time of examination. And you have to mention that my report contains so many number of sheets and so many number of envelopes, which I mentioned from the sexual medical legal examination kit. And of course, very, very, very important is the signature of the examining doctor, proper name to be legibly written, and place seal. Wherever you are working, if you have been provided with any seal, as I mentioned, should be there. In fact, most of the private setups also, people these days are having stamp and seal, so that can be used. Of course, the final opinion is only after receiving the lab reports in the following mentioned formats, and which is usually the more often than not the owners of the forensic science laboratories to be presenting to the court of law. But your job is to honestly mention whatever you have seen during your examination. So opinions regarding sexual assault survivor to be given in a case of sexual assault. And as you can see, it's obliquely mentioned as rape. Rape is a medical legal term, which you cannot actually be using in your examination findings. Now, if the opinion says there is evidence of recent sexual intercourse, that is when recent injuries to the genitals and other body parts are found and motile spermatozoa recovered from the vagina. If the opinion says remote sexual intercourse, then usually you find partially healed injuries and non-motile spermatozoa in vagina when reported late. Then comes recent penetration. If the opinion is this, then it is dependent upon the local recent injuries to genitals, but no spermatozoa recovered, condom vasectomized, finger, idlo, or other objects. Now you must remember, most of the times in the guidelines, you will find that the sampling can be done till 96 hours of the last intercourse. But very recently, a Ministry of Human Resource Development, the LNJN Institute, which I mentioned, and I happened to be fortunately part of those experts, we had done a convention, and it's been almost more than a year or so that now the guidelines say that you can sample for 3 weeks, because they have found that the sperm tend to survive in the cervical secretions or near the cervical area till 3 weeks. So if the history is pertinent enough and the survivor says that she's not douched the area or any other washing or whatever, then you can, if the history of penetration and emission was there, then you can very well sample her till 3 weeks. If the report says there is evidence of remote penetration, then there must be partially healed injuries to genitals. There is evidence of recent sexual assault, then of course you will find the recent bite marks, injuries, neck, breast, cheek, neck, breast. Bite marks can be anywhere, but injuries to genital are absent when help arrives before actual penetration occurs. Evidence of remote sexual assault, again partially healed injuries you would find. There is no evidence of vaginal penetration, but possibility cannot be ruled out. This is a very usual and very common statement which is written. When you find that there are no injuries or no spermatozoa recovered from vagina, but the history of the survivor is suggestive enough for the assault having occurred. Then similarly, you all these all charts you must not be getting confused with. I mean, you should not get confused. All this is mentioned in the Ministry of Health guidelines also, which you can refer from time to time, and you can keep them handy at whatever place you are practicing. I'll soon show you how they look like, the guidelines. And this is the format of giving the evidence for findings in support of your above opinion, and you have to mention them there, that why you say so, what you say. This is again what we have already shown. So in summary, after having the informed consent, per vaginum examination, which is the 2-finger test, we have to remember is not to be done routinely, mentioning the hymen or size of vagina, because that does not corroborate or does not help in pinning the assailant. And injury documentation, sample collection, final opinion, These all are the important broad steps which need to be followed in a medical legal examination. And having said that, of course, the samples need to be dried, air dried, and properly sealed and packed and handed over to the police, depending upon the time of the day you are doing that. Most of the times when they come in the wee hours of the night, say 1 a.m., 2 a.m., most of the times the police is not taking the samples immediately. So we are handing over the samples to the sister in charge available. And that needs to be documented in the form that we have handed over the specimens like that. And eventually at the next possible hour, the concerned police official takes the sample, and that can be mentioned through the nursing staff. Of course, as I said, appropriate treatment. This is a comprehensive nutshell approach to medical legal examination of survivor, and nothing is complete with good documentation. So at the time of if you think the survivor is fit enough to be discharged from your facility, she should have one copy of the documentation in hand. One goes with the samples to the IO, and of course one is kept at your center for record. And then you have to mention what time she should be following up with you, because there are things like STIs, and she might eventually land up in pregnancy. All those need to be followed and catered to. This is an extra. Somehow the figure is very dismal because these are the pictures taken from the actual documents. So this is comprehensively telling you that what all things are available within the safe kit. And of course, examination table, torch, and all you need to have at your facility. Curtains for due privacy, and rest other things are emergency contraception pills, and basic treatment for STIs. Everything should ideally be available at your center. I'll not go through this complete list, because any which way, if you have a safe kit, all these things are readily available there. But for those who don't have access to safe kits, or are for some way or the other are unable to procure, then this is a comprehensive list of the basic stuff which they should have at their center to be able to sample a sexual assault survivor. And these are the references. I mean, this one in particular, the orange one, it's freely available on Ministry of Health and Family Welfare website. You can visit that and just simply write in search guidelines and protocols for medical legal survivor. This was issued in 2014, and it's supposed to be universally followed all over the country. And the one improvement upon, or the addition which I mentioned, will soon be available widely. Otherwise, at least in Delhi and NCR area, we are following that. That the only difference was this extension of sampling time for 3 weeks. So that completes the comprehensive medical legal examination. And I again request you to go through the post-test and feedback, because pre-test is one which you would have already done, as certificates will be provided to participants only after receiving the feedback and post-test. So thank you one and all. And if there are any questions, I'm more than happy to answer.
Thank you so much, Monica. That was a marathon session.
Thank you.
A session which is very elaborate, but at the same time, lecture and important. Yeah.
This is what I actually do, and keep training my residents, every month. And this is a very, very comprehensive thing. In spite of going over again and again, there are many things which practitioners tend to forget. Okay. So I'll be more than happy to answer any queries if they're around.
Yeah, and we will share a copy of all these presentations to you all.
Yeah, that will be very good for the participants.
So all of you can have it. It is, while I'm really, really delighted that all of you who are present here have been present since the start of the program till now, and all of you have, the stickiness of the program has been good, but it was a little bit of a downer for us here, the faculty and us, because there were 77 registrations today. And we've just had about 25 of them participating here. So I don't know what must have happened. All 50 couldn't have had emergencies. So I'm sure must have slipped their mind.
No, there was a small confusion about, you have a program tomorrow also, isn't it?
Yeah. So maybe
is it the same or something different?
No, it's the same program.
Probably people would have thought that registering for the first day is okay for both days.
Okay.
And they can attend any day.
Okay.
A small confusion about the registration.
Okay, no problem. I think you explained it well, Jashi. Thank you very much. I would like to take it that yes, that is possibly the reason, and we should have a better number tomorrow. You know what happens is there's a lot of effort which goes into all of this. The faculty spends the time, we spend the time, and you know, if it is not efficient, we feel a little down. This is not to say that you all have not been great participants. Thank you so much for continuing to be here on this call for everyone.
I have a small suggestion, sir.
Yeah.
You can split it into two halves because this is a new topic for most of us. Because people who are working in the private have not come across this documentation and all other things. So if in the single set, it is a bit too much to understand.
Yeah.
So it would be better if it is split into two, or as you rightly said, it will be very good if you can share the lectures with
Jashi, the problem or the challenge we have with splitting it into two is that, you know, getting the same participant to do it twice, as it is getting them for one time is an issue, getting them twice becomes even more challenging. And it's a 2-hour session, but what we are doing is...
No, I understand, but the thing is, it is slightly heavier for us to understand because though there are too many topics and though the speakers are very clear, it's a bit fast.
Yeah, what we will do is we are going to have a relook at the curriculum also.
Yeah.
The feedback, like yourself, a couple of other feedbacks have also come in. So we'll see, the core curriculum team will work on it and see what best they can do. But in the meantime, we would not like to split that. Monica, there are 2 questions in the chat box, please. Monica?
Yes, I'm here.
Yeah, there are 2 questions in the chat box.
I can see where can we get these forms from, and please share the PDF if possible. So as I said, if you don't have access to the safe kits available in your, usually these forms are available within the safe kits, and safe is nothing but sexual assault forensic examination kit. If you don't have that, then you can very well download this Ministry of Health guidelines from the website MOHFW, and you would find this form at the end of the document. And very quickly, Dr. Garima, you have asked, ma'am, can postgraduate students examine the rape survivors? Of course you can, depending upon how your emergency and your one-stop center is armed. Any registered medical practitioner is under law allowed to examine the sexual assault survivor. So postgraduate very well holds a MBBS degree, and you are much better off than an RMP. But yes, when available senior resident is there, then she is actually the responding superior of the team usually, and they are certified to appear in the court. So preferably if you have an SR in the team, she should be signing and stamping. Else any practitioner who holds the degree is more than equipped. But if no one is available, postgraduate student is much better than an RNP to examine. So I hope that answers your query, Garima. How to procure safe kit, I've already told. And then now, if you belong to a government institute, many manufacturers in the GEM site are there. Rest for private practitioners, of course, we have so many places available. You can just search for safe kit. Maybe Mr. Ajay can throw some more light if some Foxy is doing some.
No, Foxy actually is not, except that you try to facilitate it if required. But many of you are already working in this area for now a number of years. You would definitely know, and government setups or the civil hospital or the civil surgeon, they would be the best one-stop shop for getting all of this.
Because I can vouch for tertiary referral centers like ours, which you all know is one of the biggest in Asia, Safdarjung Hospital. So we are having it procured through the GEM site. And these days, these latest safe kits are available, in which this there's a booklet sort of medical legal form, which is already in duplicate. And as I said, you don't have to make the copies then. One can be there with the survivor, one gets into your records, at least for 5 years you have to save that, and one goes to the forensic science laboratory.
Perfect.
That we don't have to.
Thank you so much, Monica.
Thank
in the
you.
chat box, we have posted a link to the post-test and feedback. All 3 are the same links. You can click on any one of them and go ahead and submit your post-test and feedback. On that note, thank you so much, Monica, once again, Meeta, Gauri, Yasmin.
Thank you for having us.
Yeah, it has been simply wonderful. Sorry, Yasmin and Amita, I missed your session earlier, but I hope it went well. And we hope to have your involvement in future programs also as they are coming up. And we'll keep you updated for all of that.
Thank you, sir. Thank you.
Thank you,
With that,
sir.
have a
Thank you so much, sir.
wonderful evening, everyone, and have a lovely weekend. Thank you so much.
Bye.